This topic hasn't really gotten a ton of coverage over the past several years, and I wanted to maybe go back to the basics. You've heard a lot of cutting-edge technology, and you're going to hear some more, but I thought if we go back to the basics with this particular topic, that would be helpful. This is Caminito del Rey. It's apparently one of the most treacherous and dangerous walking paths in the world, somewhere in Spain, and I thought it was an apt analogy for elbow trauma, because elbow trauma is fraught with pitfalls that we have to keep in mind in order to avoid complications and optimize outcomes. So the first is that elbows tend to get stiff in general, more so than other joints that we treat. If we have to immobilize elbows for a prolonged period of time in casts or splints, either without surgery or after surgery, we can create permanent stiffness that'll limit the patient's outcome. The second thing that's unique about elbows is there are several important nerves that are in close proximity to the work that we do, and we'll talk a little bit about those. So we have to be mindful of those nerves and protect them so as not to create an injury that impairs function. In addition, the bones of the elbow, in particular the lower part of the humerus, tend to be somewhat more fragile than other parts of the body, and this can make getting stable fixation after fracture surgery difficult. We'll see in a minute that the anatomy of the elbow is somewhat unusual, and so interpreting elbow x-rays can be difficult, and overlooking subtle injuries can occur. And finally, while we sometimes encounter an injury to this or that bone, complex or combined injuries in the elbow are not uncommon, and those can be somewhat complicated to treat. So again, it's helpful to go back to the basics and work based on first principles to make sure that we can navigate elbow trauma treatment well. And these are the first principles that have been described by AO, which is the international governing body for the education and training of orthopedic surgeons on how to manage trauma in any part of the body. And we'll sort of work through all of them in the context of the elbow using cases to illustrate some of these points. But first, a few words about the anatomy. So the elbow, in contrast to other joints in the body, is made up of 3 bones. We have the ulnohumeral articulation, which serves as a hinge joint to flex and extend. But we also have the radiocapitellar joint on the outer part of the elbow that serves as a pivot joint to rotate our forearm and rotate our hand palm up and palm down. We, in addition, have some very short and stout ligaments that help to stabilize the elbow. Dr. Aversano talked about the ulnar collateral ligament on the inner part of the elbow, the Tommy John ligament that stabilizes the elbow during throwing. And we also have the lateral ulnar collateral ligament complex, a series of ligaments that protects the elbow from dislocation. And then we have a series of muscles that cross the elbow to provide secondary stability. We have the muscles on the outer part of the elbow that help to extend the wrist and fingers, and the muscles on the inner part of the elbow to help to flex the wrist and fingers. And again, they also provide secondary stabilization to the joints of the elbow. And finally, those important nerves that we talked about. So again, Dr. Aversano talked about the ulnar nerve, which lies right up against the bones that can be broken in between those 2 bony prominences, and it's in close proximity to the work that we do in fracture care. And then the important radial nerve, which we'll talk about as well, which provides important motor and sensation function to the hand and fingers. So the first basic principle of elbow fracture management is to protect the nerves. This becomes particularly important when we're dealing with fractures that not only involve the joint surface, but extend further up the humeral shaft like this one. This is an individual who fell and sustained this complex distal humerus fracture, and you can see how long of a plate we have to use to provide adequate stability. That plate lies right where that radial nerve circles around the humerus bone and lies on top of the bone, actually. So we need to know about the nerve, identify and mobilize the nerve to slide the plate underneath, and then we actually let that nerve rest on the plate when the surgery is done. So we really have to be vigilant to protect that radial nerve. Otherwise, the patient will lose function for at least 6 to 9 months after surgery. The second principle that we need to apply in fracture care is visualize the fracture well. And we do this by being very thoughtful about the approach that we use navigating through muscles to get down to the broken bones. So this case can be illustrated with radial head fractures. That disc that rotates on the outer part of our forearm can be broken in a simple or complicated way, and we need to determine how we're going to fix it, which will then dictate how we approach it. So the right panel there shows at least 2 different approaches that we use for the elbow, and the basic principle is if we just need to treat an isolated radial head fracture and nothing else, we might choose that Kaplan interval because it provides us a very good exposure to the bone, but it doesn't really show us anything else. Instead, if we have an elbow dislocation and a fracture of the radial head, then we might choose that Coker approach, which allows us to both fix the radial head and also repair the ligament. So here's an example of a 25-year-old woman who fell off a skateboard and sustained this very complicated radial head fracture. in addition to a fracture of the tip of the coronoid and a tear of her ligament. So we need to adopt the right approach to the right patient, which in this case is going to be that Coker approach, so we can fix the radial head, in this case with a plate and a series of screws, and then on the way out we're going to repair the collateral ligament to provide her enough stability so she can move that elbow early and regain near full range of motion and optimal functional outcome. Another example of the appropriate approach is the coronoid. So this is a very important piece of the ulna. It's this tip of bone here that serves as a very important stabilizing structure and can either be broken at the tip or at the base. And depending on how that coronoid breaks, that's what's going to dictate what approach we use. So this is a very helpful approach called the Taylor sham, which was described way back in the 1960s. And in this approach, we elevate the entirety of the muscles off the ulna in order to see the base of the coracoid well to fix the entirety of the bone. So another example here of a 24-year-old man who fell while playing basketball, and he has a fairly large coronoid fracture. So for this individual, we're going to choose that Taylor sham approach in order to see enough of the coronoid to fix it well. And this is the end result. We apply a plate and screws and a separate screw for supplemental fixation to provide enough stability to allow that patient to move early and regain near full range of motion. A final example of the importance of the approach is this injury. This is a 72-year-old individual who had a total shoulder replacement by my partner just 6 weeks before he fell. He fell and unfortunately sustained this complicated intra-articular fracture of the joint surface. And if you notice on this bottom panel here, we can't really see the joint surface because this piece of the ulna called the olecranon is in the way. So in order to see this particular fracture well, we actually need to create a fracture. We need to cut the olecranon, as you can see on this right panel, move that piece of bone out of the way in order to see the broken bone and fix it, and then repair the osteotomy on our way out. So you can see this intraoperative x-ray where a piece of the olecranon is missing because we've moved it out of the way in order to do the surgery. And this is the end result. In this individual, we see a couple plates to fix the fracture, and then a third plate to fix the osteotomy that we created on our way out. And again, the principle of seeing this fracture well in order to fix the fracture well to get this patient back his range of motion. So once we see well, we then need to piece the various fracture fragments together in an anatomical fashion as the second principle of fracture management. And the way we do this is by working stepwise. So when we approach these complicated fractures of the lower part of the humerus, we first just want to focus on the joint surface and ignore the shaft. And we piece those joint surface fragments together and hold them together with wires. And then we put screws just in the joint surface fragments to create a single joint surface segment. And then we assemble that joint surface segment to the rest of the shaft and fix it with a plate and screws. Once we do that, we need to make sure to create a construct that's stable enough to withstand therapy afterwards. So this is the third principle of elbow fracture management. And the way we do this is in two ways. We use plate technology to our advantage. So the first way is with what we call compression plating. We actually use the plate to compress the pieces together. We first put a screw on one side of the fracture to fix the plate to that one fragment, and then we place a screw on the opposite side of the fracture on the edge of the screw hole. And as we tighten that screw, the plate is going to slide and the pieces are going to squeeze to one another, which creates inherent stability and also stimulates the osteoblasts to begin to heal the fracture. The other piece of technology that we use is locked plating. So you can see here that the screws in this plate have threads on the head itself, and the plate has threads as well. So as we place those screws, the screws not only capture bone, but they also capture the plate. And this creates a fixed angle construct that is more resistant to pull-out and failure. The final consideration for stable fixation is plate orientation. We can place two plates in parallel, or we can place two plates perpendicular to one another to create a stable construct, and both of them have benefits and disadvantages. In essence, though, what we want to do is apply the plates to suit the patient's individual fracture pattern. So this individual, again, has a very comminuted, complicated distal humerus fracture, and in this case, we're going to place a plate that's appropriate to this patient's worst components of his injury. So we place them perpendicular to stabilize the fracture best in this case. This is a slightly different example of a patient, and you can see in this example, these pieces of her joint surface are broken, small, and extremely fragile. So in this person, we didn't choose parallel plating, we didn't choose perpendicular plating, instead we chose a combination of 3 plates to provide ideal stabilization for this unique individual to provide enough stability so that she regained full range of motion. To this point, we've talked a lot about how to manage the broken bones, but we have to keep in mind that certain injuries are more complex. This is an example of an injury pattern that involves not only fracture of the bones, but dislocation of the joint itself. It's called a terrible triad, and it involves a dislocated elbow that on the way out broke the coronoid and also broke the radial head. And it got its name because it has a higher incidence of complications, including stiffness, recurrent instability, and also failure of fixation. So when we approach these injuries, we have to be very thoughtful about addressing each and every component of the unstable elbow. So we move through a series of steps. We first want to determine the radial head. How are we going to fix it? With plates and screws, or instead by placing a metallic spacer? We then want to look at the coronoid and determine, does it need to be fixed, and if so, how? With sutures, screws, or plates. And then we begin the work. We start deep with the coronoid, address the coronoid, and then move superficially to the radial head. And then finally, on our way out, address the collateral ligaments that were torn at the same time. This is an example of a terrible triad injury where this individual has that combination of a dislocated elbow, a coronoid fracture, and a radial head fracture. And we address this injury with a spacer and suturing the coronoid with sutures, and then on the way out, fixing the collateral ligaments. A final case to illustrate the point. This is an individual who has a terrible triad, but on top of that, also has an olecranon fracture similar to the osteotomy that we created earlier. When we address this individual's fracture, we're going to take the same systematic approach. We're going to start deep with the coronoid and use a plate and that extended Taylor sham approach. We're then going to fix the radial head, in this case, thankfully, just with a single screw. And then on the way out, fix that olecranon with a plate and a series of screws. And finally, as the last step, repair the torn collateral ligaments. And again, the tenet is to create enough stability to allow this patient to move early to regain full motion and have the ideal functional outcome. The final principle in elbow trauma management, as I think Paul already discussed with rotator cuff repair, is partnering with our therapists to develop a thoughtful program that respects the fixation but also moves the elbow early. So in the OR, we want to do an assessment of stability in order to make sure they're going to be stable enough to withstand the forces that are going to be exerted on that elbow. We then want to choose the ideal immobilization depending on which collateral ligaments were torn and which collateral ligaments were fixed. And then we want to move through a very slow and progressive range of motion program, usually supine with the arm overhead to allow gravity to help us rather than to hurt us, and get them more and more motion week by week towards near full recovery by about 6 months. So in summary, in managing this complex, fraught set of injuries, we want to adhere to first principles and maintain a systematic approach for our more complex injuries, but we allow nuance for each individual case. We want to be mindful of pitfalls in order to stay out of trouble, primarily with the nerves, and then execute a careful and thoughtful rehab program in partnership with our therapists. Thank you very much.